they made very significant improvement. This one is very possible. I must emphasize this one. It is very, very possible to keep our facilities clean, people to wear uniform. You go in the health center for a senior officer, you ask a nursing officer, say, are you a staff or are you a patient, a caretaker? Says, I'm a staff nursing officer. Wearing what? No uniform. So I think those are the things we are trying to, actually the emphasis in quality improvement, if I may also add, you use what you have. Work with what you have. Nobody will blame you for what you don't have. They may blame you for not being, if a manager, for not being, taking steps to address or innovative and so on and so forth. So the issue of resources, for us, we appreciate it's a big concern, but it should not be an excuse for any facility not to perform well. Some are already performing very well, and we can mention some of them. Kiandongo Hospital, one of the one which I think scored above star 3 or 4. And the private facilities, they're able to achieve the scores reasonably well. So I think that point, I think I've tried to address it. It's always the excuse we get when we talk about quality improvement. Other people are very busy. They say for us, we are very few, we are very busy, or there are no resources. When you discuss, they talk about vehicles, which is true and very important. But I think let's try to see where we can put our hands on and make a change. Then CDC, so I didn't get your name, the budget. The budget is one of the, as I said, the budget is still a bit crude, but it gives you a rough picture of what we need. And we are going to work on this one, certainly, and come up, especially at regional level. For them, they appreciate their context better than any other person. So we think they are going to sit down and do a more detailed assessment, analysis, and also mobilization. Most important, mobilization for resources. Most of the places, most of the implementing entities in the sector, they are crying shortage of resources. So we need to see that resources are available. And as I said, I once again call upon the partners to come and work with us, and we get the resources available so that we can train people, we can have the tools available, we can develop systems. We have to do supervision, we have to do mentorship, we have to do monitoring, and the support supervision, among others. So, forum for sharing, mentors to meet, I think it's the point noted. We need to take it to, I think, stakeholders, generally. We have the quality improvement committees at the national, at the regional, and in the districts. The partners, I think they should be captured in that forum. But for the mentors, I think we need to plan for that. Dashboard is, of course, the way to go now. We have already shown you what we have done, and we can still definitely do more to have dashboard. So at a snapshot, you can appreciate the performance levels, and then you can make a decision from an informed point of view. Chair, I think those are the questions which were raised.
Martin, please, I think it deserves a better one. Have any one or two issues from our colleagues in the space? Please let us have it, or have them, one or two. Okay, we have about 3 issues from our colleagues online. One of them is from Louis, I'm Luis from Mubende. Thank you, Martin, for coming up with that assessment tool. I pledge to utilize the tool with my fellow health workers for quality improvement at Mubende Regional Referral Hospital. Thank you so much, Luis, for that very good and very encouraging comment. The second one is I will start when. Okay. Thank you, Martin, for the presentation. Health facility quality of care assessment program is good. However, should be done routinely to avoid setbacks and stick to the culture of quality. These are comments. The third one, the third one is a hand online. We want to allow you Madam Eva Gakumba, please give your comment or your question. Madam Eva, you have the platform. Madam Eva, just unmute yourself and make your comment. Just unmute yourself, Eva. Oops. Eva, just unmute yourself, please. You cannot unmute her. Okay, let us now go to Geoffrey. Geoffrey Kaita. Geoffrey, can you kindly make your comment or ask your question?
This is Godfrey Kaita from the African Field Epidemiology Network, AFINET, a senior epidemiologist. Thank you, Martin, for the presentation, and thank you, the team, for organizing this. Uganda. My comment is on the performance assessment. It's good, it's happening. We get to see regions which are vigilant, like Karamoja, having at least a set of assessments that you can use to make sense on what is happening and whether improvements are happening in that area. But the bigger part of the country is missing these regular assessments, like you did mention for the Midwest, part of the region where no assessment has happened so far. Now, that's a very big challenge because we never get to see the national picture. And now coming to regional and at national level, you never get to see where to really come in and support all the rest. How are the plans of getting this moving from being voluntary and dependent heavily on the donor to get some points that one can use to put together to see whether we are making progress in the country or not? Over.
Thank you so much, Godfrey, for your comment. Inside here, do we have one? I want to take one comment or one question from. Okay, Martin, you want to make a comment on?
Thank you, colleagues, for the comments made. Luis, I think, was just appreciating and is going to use the tool. Please go ahead. Please go ahead and get other players to work with you. I think that's the most critical issue we need to have put into consideration. Having all the actors available and participating, and then being done routinely. That's our prayer. It's our dream that is done routinely. We have it annually, and the facilities quarterly, and then the gaps are identified, and data is put to use. The gaps are identified, and they are put to use. Then, Dr. Kaita, thank you also for your observations. Yeah, I think we are making progress. Your concerns, I think I took note of that. and members are all listening here, that the assessment should have an impact. That is also, I think, what we are emphasizing. The assessment, wherever it is done, it must have an impact. The response must be, feedback must be given, and action areas must be identified, and then we see how we can improve the gaps. And of course, donor dependency, this is where we are for now. We hope things will improve and we get additional resources, especially from the government of Uganda, to fund this activity, which is quite expensive, but I think progressively we shall reach there. Thank you very much.
Thank you so much, Martin, for your presentation and for the responses provided. And thank you so much, the audience, for your attention. Let us give Martin an applause as he walks back to his seat. Thank you so much. Ladies and gentlemen, you will agree with me that in the health industry world over, a day doesn't pass without us talking about client-centered care. And us asking ourselves or wondering if our systems have done anything, or if they have done anything, to what extent that has contributed to the provision of client-centered care. And this morning, we are privileged to listen to one of our gurus in quality improvement, talking to us about to what extent has the healthcare systems provided the environment for provision of client-centered care in Uganda. And this is none other than Professor Rhoda Wanyenze. Just a brief introduction of this keynote speaker for this morning. Professor Rhoda is the Dean of School of Public Health, and specifically she works in the Department of Disease Control and Environmental Health at Makerere University, with expertise in infectious diseases, sexual and reproductive health and rights. She has 25 years experience in health service delivery, including clinical experience, research, teaching, program management, and policy development. Over the past 8 years, Professor Rhoda has served on several boards in different organizations in this country. This morning, we are privileged to have her address us on this important topic. To what extent has the health care systems provided the environment for provision of client-centered care in this country? And I have the honor to invite her to address us. Professor Rhoda, you are welcome.
Thank you.
And clap.
Thank you for the kind introduction. Good morning, ladies and gentlemen. Hello, can you hear me? Hello? Can you hear me?
Yes, we can hear you.
Okay, great. Thank you for that kind introduction, and good afternoon, ladies and gentlemen. And
Professor, kindly increase your volume so that we can clearly get you.
Can you hear me better now? Can you hear me better?
Increase a bit, not yet.
That's the max for me for this, unless I change to a different gadget to use for connection. You can't hear me
IT,
at
what do we
all?
do?
Is that okay?
Because I feel she's still low. Okay, let's go with that, Professor. Sorry about that.
Okay, sorry. I hope you can hear me. Pity if I'm not able to get through.
That is better. That is better,
you.
Professor.
So
that is better.
Okay. Okay, thank you for the opportunity to share my thoughts around this topic of client-centered care in Uganda. I will speak to a number of issues, but I will start with a broader context. From my public health perspective, it's not enough to start with client-centered care without looking at the context within which we are working, because it's influenced by a lot of issues within the context that we must also pay attention to. So I'll start with that and then go through the definitions and the framework and the thoughts around the challenges and how we might be able to overcome them. So for a start, I need to emphasize that what's going on around us in Uganda and other countries in Africa are pretty similar challenges, still struggling with poverty after many years, and issues around rapid urbanization and people are quickly moving from the rural to the urban areas. This comes with a number of challenges in relation to healthcare, and especially in terms of addressing the issues of the urban poor populations. We have major issues with climate change, and this affects a lot of issues around us, including food security, among others. And then we have a growing challenge with pollution, many ways, whether it's air, water, and other issues. We've talked about issues of migration, partly, but there's also the general challenges with environmental degradation. And then we have a very rapidly growing population that we need to plan for and service. So as we speak client-centered approaches, we need to be thinking how we can accommodate the increasing populations and how we can be able to turn off the tap in terms of ill health, making sure that we promote health and prevent disease. We have disasters and emerging epidemics like what we are going through right now. Now, this complex wave of interconnected issues that drive health, many of them are operating outside the health sector, and many of them are operating beyond the patient care issues that we are discussing right now. And unfortunately, they do impact on client-centered care, and we can't run away from it, because the quality of our population and how empowered they are in the broader sense will also influence how empowered they are to seek care and to demand quality and to be part of the solution in terms of addressing the issues for client-centered care that we are talking about. Also, to have in mind is that we have a rapidly growing and changing disease burden and patterns out there across the continent, but also in Uganda. Similarly, that figure shows the most recent burden of disease assessments that have been recently disseminated and published in various papers. And you can see that there is a reduction in disability life years lost as due to conditions related to maternal, neonatal, and communicable diseases, nutritional conditions. But this is, it seems, absolute numbers, especially with the rapidly growing population and the increasing denominators. And then we also have these persistent infectious diseases and neglected tropical diseases that we have to deal with. And this is growing into the morbidity issues, disease, because they might have multiple conditions that we need to deal with. And there is that we can't afford to neglect any. I thought I should share this slide. It's a 2018 publication by WHO, but it still is depicts very well the issues that we're struggling with in terms of outbreaks. according to this publication, there were about 96 outbreaks in 2018 in several countries in sub-Saharan Africa. And as you can see, Uganda in red had the largest number of outbreaks that were reported. Whether it's because we have a very strong system that can detect these and report them, it does represent the actual threats on the ground. And as we think about the client-centered care, we also have to think about integrating these for emerging and re-emerging infectious diseases and outbreaks. Now, going back to the issue of client-centered care, there are various definitions out there. This definition is one that is very commonly used here, but also elsewhere, in terms of delivering care in a manner that is respectful and responsive to the individual needs of patients, their preferences, their needs and values. And I highlighted the issue of patient and clinical decisions because I think we should not be speaking just about people that are sick. We should be speaking in the broader sense about health promotion and prevention services that we deliver, because we are not just about patients and we are not just about clinical care. And if we don't move this beyond patients and clinical decisions, then we shall continue to get overwhelmed with the large numbers of patients. And when we do get overwhelmed, then quality becomes very difficult to deliver. So we need to extend this conversation outside the healthcare setting. Why is this important, the client-centered care? Like I mentioned earlier in one of my first slides, the burden of chronic diseases that require long-term care is growing. Multimorbidities, many of us are moving around with quite a number of complex conditions. It's not just one or two, and they require complex care needs. We need to be more efficient with the resources. We've just had the Assistant Commissioner talk about challenges with funding, even just for assessments, but we need to be responsive to the needs within this context. Patient and provider satisfaction are some of the documented outcomes when we deliver good client-centered care. So we ourselves as providers feel happier when we deliver good care. And I've always, when I speak to my colleagues, I sometimes ask, what does it really feel like when you are out there and you're not nice to the people that you serve? Sometimes people complain that care providers shout at them. And sometimes I ask, how does it feel like when you go back home and you've been shouting at people that need care and compassion? How does it really feel like? And sometimes we say we don't have enough resources and we don't have what it takes to do a good job. But does it feel better when we shout? Does shouting bring money? Does being rude and disrespectful solve the problem? So I think we need to begin to question this whole issue in terms of our professionalism, our behavior, and how that works. When you do a good job, you feel happier, you're more satisfied, and it's not just the patients that get away with satisfaction. There's the whole issue of confidence and trust. This is a growing area right now, and for response, you must is really crucial. So, walk the talk. In terms of the improvements in health outcomes, the literature is still mixed. Some literature shows that when we deliver client-centered care, we have better outcomes, but other studies are not necessarily showing this. So we need more research in this area to track what is happening and the outcomes. These are principles of client-centered care. And you are familiar with them, so I'll not go so much into all of them. The respect for patients and what they desire and their values, making sure that they are well informed and are able to be part of the solution, including co-creating healthcare so that it's responsive to their needs. But I will just emphasize the issue of integration and coordination. Looking at the issues of multimorbidity and being able to look at an individual and not a disease, we need to be able to coordinate better. We need to integrate services in the way that we develop and provide these services. These are some of the issues that we need to really look at in a broader sense. There are complexities of involving families and friends. This is something that has been a challenge for us in many ways. We have talked, for example, about sexual and reproductive health services and maternal health services, and how to include even just the significant other, who is the spouse, in the decisions becomes a challenge, let alone involving the rest of the family. And some of the challenges are partly in the culture, but also partly in the professional approaches that we have been used to, but also the infrastructure and the context and the ability to be able to accommodate the extended significant individuals in one's life. So I'll let the rest pass in the interest of time and move on to the framework for Uganda. I will not go again into so much details, except to say that when you look at the number of policies, when you look at the number of tools that we have in place, it looks like we are really set to go, whether it is the how to, whether it's the what to, and whether it's the governance structures to provide the oversight. And now, from what we've just heard in the presentation that has just ended, we also have so many tools around how to assess. But I ask myself, to what extent do we actually act on what we assess and find? And to what extent are these structures really working for us? What level of leadership, what quality of leadership do we have across all these structures to solve problems? Because I believe that when we talk about the health system, complex as it is, that the real key driver of this is leadership. And this leadership is not only at the top. Each and every one of us is a leader where we are. Can we provide that leadership that can solve problems? If you can't solve problems, then you are not a leader. So for me, this is the real gist as we look at the policies, as we look at the structures and all the frameworks that we have in place. We need to pay attention to the leadership. And when we say leadership, you don't point to the next level up. Leadership starts with me, and leadership starts with you, wherever you are. The frameworks at the subnational levels, again, you know all about this, and I don't have to tell you what exists where you are. You can see all of them. We have so many structures in place, which ideally, if they functioned, quality perhaps would not be a major issue. So where is it, and where are the issues that we are remaining with? We have the Patient's Charter, and this defines a lot of issues around the patient's rights. Again, these are available. I don't have to dwell onto this, but perhaps we also maybe need a charter for the providers. Will this actually make a difference? Are we short of tools? And is the provider charter what will do it for us? Or do we need much more than that? Responsibilities of patients and responsibilities of providers. Again, these are areas that are clearly defined in many of the documents that we have. The survey that has been conducted recently, I'll just look at one or two slides in this, looking at issues around client satisfaction, which is one of the real key issues within client-centered care. And that slide summarizes a picture that doesn't look very good for all of us, wherever we are. Why does that picture look the way it does? When I look at this data, it looks worse than some of the surveys I did myself as a student almost 20 years ago. So some of these indicators just need to get better. The client satisfaction, what has happened to it? We had higher figures many years ago. So it's up and down, and this is across both the public and the private sector providers. So we have a major issue here, and we need to pay attention to it. Is it the needs and expectations of the clients that are changing, or is it what we deliver, and how can we bridge that gap? The variations across the region, not so impressive. Some regions might be a bit better than others, but clearly we are not doing well. And this is something we need to pay attention to. To what extent do we act on what we find? Are we able to document the actions that we take after these surveys? And are we able to demonstrate that we are doing better when we do subsequent surveys? the action based on what we find is a critical issue. I'll share with you some results from an assessment, a mixed method study, which was done to review the rollout of the differentiated service delivery models for HIV. And this is one of the really good examples of client-centered approaches, because we try to respond to the needs of people in terms of how frequently they should be seen, where they should be seen, who should see them, and be able to ensure that we deliver quality in a manner that is regulated, that is linked to the health system, and that offers a mechanism for referral to the next level if you need intervention beyond the lowest levels. So it is a very good example, and perhaps it offers some lessons in terms of how we can then do a comprehensive mechanism to respond to client-centered care needs. So this is a summary of what we found when we did this assessment based on the DSD standards for rollout. Many facilities that we visited were actually doing well at various levels based on the performance domains defined by the Ministry of Health. However, we found that the rollout of the community models was not as good. There were very few people that were enrolled on these models based on the targets set by the Ministry of Health. And I'm highlighting this because when we get to satisfaction, you will notice that the users were more satisfied with these models, but we have fewer people on these models and the rollout is not as good. But we also found that the QI projects related to the differentiated models were not happening as often as expected. In terms of the enrollment to various models, we found that a very large proportion of patients were still on the facility-based individual models, contrary to the expectation of the Ministry of Health. More than twice of the patients were actually still on these models, and the rest of the other models, including the fast-track distribution of drugs, as well as the community and the group, facility group approaches, were still quite low. It's possible that this has changed over the last 1 year, especially given the current circumstances, where we are having challenges with people coming back to the health facility, and we are beginning to utilize more of the community and client-based approaches to ensure continuity of care within COVID. So we wait to see what is happening around this, and we actually have a survey that is just going on right now, and we will be able to assess how this might have changed in the face of COVID. In terms of categorization of patients, whether they were stable or unstable, and therefore a decision to apply the specific models, we found that a significant proportion of these patients were not even categorized in terms of whether they were stable or not. And even those that were not categorized had actually been placed on certain models. So the decision to get them to these models was not yet fully informed. At the same time, we also found there was a lot of misclassification of patients when we applied the criteria for determining stability, and several unstable patients were otherwise transferred to models for stable patients. So this is something that was happening, and I hope that it has changed a year later, and we will see this based on the ongoing survey. In terms of who had been misclassified and was on models for stable patients, we saw people that were not virally suppressed, we saw people that were not adhering to their treatment, and those that had been on treatment for a very short time and with side effects, also being placed on models for otherwise stable patients. The other issue that we need to flag is the patient awareness of the different models, because for us to be able to have good client-centered care, we need to be able to fully inform our patients so that they are part of the decision-making. But patients were hardly aware of certain models. The fast-track drug distribution models were known by just about half of the patients that we interviewed, and then the client models were hardly known by the patients that we interviewed. The choice, when we interviewed the providers, they said it's the clients who make the decision. But when we asked the clients who had been on the some of the differentiated models who made the decision to move to that model, 67% said the provider made this decision. So that was contrary to the thinking that the providers had, and perhaps reflects the disconnect that we have around the issues of decision making. In terms of patient satisfaction, this looks much better than what you saw earlier. Perhaps we are doing much better with disease-specific programs such as HIV. The level of satisfaction was much higher. And we can see that the efficiency of service delivery, how quickly people went through the system, and how they were treated by the provider, the humanness of the interaction, were those areas that were lowest, but still much better than what we saw earlier. And we also note that this is what they value most. We did also a time and motion study to objectively measure how long they were spending within the facilities. And it's very surprising how long they were waiting. The satisfaction also varied by model. Like I mentioned earlier, the community models seemed to fare better, although this was generally high. And so you can see this again about the satisfaction for the community models is all within the 90s. So they were much happier within these models, but we had fewer people on these models. And then in terms of the waiting time, you can look at the facility-based individual models where people had to wait for so long. That is so many hours. That's in minutes, but that is so many hours of people waiting. And when we tracked further, we noticed that about 80% of that time was spent just waiting to see a provider for those that wanted to see a provider. So these are some of the real issues using the example of HIV and the the differentiated service delivery models. In terms of the health system challenges, many of these we are familiar with, but these are the issues that we need to address. We have too many people in acting positions, too many positions that are not substantially filled. That means people might not have the confidence to be able to make decisions, but also the continuity of their service becomes an issue and follow through. So we need to do more. We still have issues with the supply chain and making sure that the products are available. And this is an area of a lot of dissatisfaction among other studies that we have seen. So it needs attention. The information systems, we have challenges, the coverage of the electronic medical systems, unique identifiers, and we have to note that if we have to have continuity and a life course approach, we have to be able to track individuals as they come in and out and as they go to various facilities across the country. So it's something that we need to deal with. The satisfaction surveys are not consistently done. They are expensive, but we need to get innovative. We've had the discussion around the self-assessment and the actions also taken based on self-assessments. Perhaps that would reduce the cost, and it will integrate a culture where we can assess ourselves and identify problems and deal with them, rather than wait for an external assessment, which perhaps could be done less frequently given the cost. The issues of human resources, this remains a challenge in terms of making sure that we have enough individuals to do what is supposed to be done, but also that we have people that are well prepared to be able to do what is required. Health financing, this is a problem, and it seems to be deeping further. In fact, we are worried about what will happen now that we have COVID. COVID has not only taken away a lot of money, but COVID perhaps is also making our economies crumble, and because of that we might have a lot more issues. And then we have challenges with the coverage of insurance, health insurance, so that we can be able to access services when we need them without getting into catastrophes in terms of personal and family household financing. We have a number of issues with service delivery and the indicators have improved over time, but perhaps not fast enough. What are the other challenges that we see in a broader sense? The client-centered delivery of services requires integrated approach so that we are looking at individuals and not as a disease. But many of the interventions we have are still very much disease-specific. So we see HIV interventions, we see TB interventions, we see malaria interventions, and now we are also beginning to see those that are targeting non-communicable diseases. So when and how can we actually have a comprehensive mechanism that can deliver what we need through the life course? The unaligned roles of the stakeholders and the issues with the key stakeholders, the culture of empowering patients as equal partners. Can we have patients as equal partners, clients and service users, to be part of the co-creation of health services and their improvements? To what extent are they involved in improvements when we identify challenges through the surveys that we do? There is also the professional challenge of health providers being able to empower clients and involve them. Many times we feel they don't understand enough, that they are not capable of making any contribution, and these kinds of feelings still persist. But then we also have issues with linkages as well as continuity across the continuum of care, the community systems, and increasingly the issues around self-care. Self-care is a very critical tool that is going to be very useful in terms of bridging the gaps towards universal health coverage, but we haven't yet fully integrated it, and its linkages with the formal health system is not yet fully clarified. We see in some disease interventions, for example, HIV, with the differentiated service delivery models, that the self-care models are growing, but in the broader sense, we don't always see this. So how can we bridge some of these gaps? I will not go through this entire framework, but it's my sincere belief that if we are going to improve client-centered care, we have to look at the broader health system. And there are some of us whose day-to-day work is about client-centered care and quality issues, but we have to connect with the broader health system. And we have to connect with the broader system that also goes into health promotion and prevention. And this has to be extended into a multi-sectoral action, especially targeting those sectors that have the greatest impact on the determinants of health and health outcomes. This is something we can't run away from, because if we do, then we shall not close the tap. We shall have many more people sick, and when many more people are sick, we shall not hold. Our system shall not hold, and delivering quality will not happen as well as we would like to see. So we need to have this broader conversation and be able to activate the broader sense and the context as we talk about client-centered care. Now, when we talk about client-centered care, one of the key issues we can't run away from is empowering communities, having communities as part of the solution. And this is one of the key concepts that's coming up with self-care that we are now discussing. We need to be thinking about self-care, how individuals, families, and communities can be part of the solution in promoting health, preventing disease, and also supporting people who have ill health in terms of their care, in terms of rehabilitation if they have disabilities. When people are empowered and communities are empowered to participate, then we shall move the needle in terms of achieving client-centered care. I have highlighted the issue of trust in the system and trust in the quality. The issue of trust is becoming really, really important. And I think moving forward, we are not going to make much progress unless we pay attention to the issues of trust. Trust in the system, trust in what we deliver, and we need to work around this. The other broader strategies, looking at a comprehensive multi-level and multi-stakeholder intervention base, looking at the patient, looking at the provider. There are the charters, but there is also the enabling environment for them to be able to achieve what is prescribed within these charters. If we move from the patient and eventually have one for the providers, how can we actually make this happen? The structural and contextual issues, including the tools for performance that extend to very basic equipment, supplies, and what we need to be able to deliver. And then the comprehensive, again, multi-stakeholder performance tracking, and not just tracking, but action based on what we see is something we need to pay attention to. We need to review and act on the feedback from clients. We might have so many suggestion boxes and they might talk and talk, but when we don't act, they will stop talking and then we will drive them away. So we need to act and we must be seen to act. And then the issues around the continuum of care and the life course and looking at individuals rather than looking at disease in a fragmented way is something that we need to look at. And as I end, I need to emphasize leadership again, leadership, and leadership. And leadership is not just about managers, it's not just about the central level Ministry of Health, it's not just about the district health teams. Leadership is for all of us, even the day-to-day nurse, a midwife that's delivering a service out there. And leadership also through the client networks. That leadership across all levels is what is going to deliver us. But then we need to be more innovative. How are we going to deliver this? It sounds like a big monster. How are we going to deliver it within the context of limited resources? We need innovations. We need to think outside the box. Maybe we need to tear the box, like some people say. We need innovations. We need to document what is working. So we need more evidence. We don't have that much research in this area, especially since this concept of client-centered care came into being. We need to be able to do things differently. We just can't continue business as usual. Thank you so much once again for the opportunity to share my thoughts with you, and happy to hear what you think about the next steps. Thank you.
Thank you so much, Professor Rhoda Wanyenze, for that elaborate presentation. I want to ask the audience to give her a better applause. Thank you so much, Professor, again, for making time to address this conference on such salient issues that we are really grappling with. And thank you, audience, for your attention. Oops, very, very engaging speech. I'm very sure that all of us have learned, and we have also been challenged in a number of statements that she has made. I don't have much time to point out a few things, but I want to just say maybe one or two. Involving clients as partners as we provide care captured my attention. Not just thinking about them as people who cannot do anything about the care system, but taking them as partners, as our co-workers in the system. What do we do? What have we done? What are we planning to do about the findings that we get in our surveys? What have we done about them? We have these findings with us, a number of them. What have we done? Do we have evidence that we have acted on some of these? I say there is not much time for me to make a lot of comments. The issue of leadership. Leadership is not that person above me or the other person 3 steps above me, but she says leadership begins with me and you. Leadership in healthcare impacts on the quality, impacts on what everybody does in the sector, impacts on what the client will take home or will conclude about our services. And I have many, but lastly, she leaves by posing a question. What can we do to improve on issues of leadership and human resources in the context of limited resources? What must we do? Yes, we need more human resources. We need to train people in leadership and all that, but we don't have resources. They are limited. Then she says, what can we do about that? She recommends innovation around this. And the last one, which she ended with, can we think outside the box? Or we have thought so much outside the box for a long time. Now she's proposing, can we tear the box? Yes, we come out of the box and tear it and even think without the box. Think without the box. That is the other challenging statement that she has left with us. Thank you so much, Professor. We appreciate your works. At this time, I want to announce some good news that we have earned our break. We aren't going to discuss this presentation, this speech. We have earned our break, but before I dismiss you for break, it is a nutritional break, by the way. Before I dismiss you for break, okay, so before I dismiss you for break, I want to ask the program managers of this conference, one of them to come over and tell us what we are going into. And before I relinquish the seat, I want to say thank you so much for giving me the opportunity to lead you in this morning session. Program manager, please.
Let's give a round of applause to this morning's session chair, who has been none other than Dr. Agwe Batesachi. Thank you so much. Another round of applause to him because he has kick-started day 3, and which is our last day here. As you had already mentioned, we are going for a nutritional break. But again, let me join him again to thank the 2 presenters who have heard this morning. One is our own from the department, Dr. Martin Sendiona. Again, looking at quite of care. Thank you so much. And of course, Professor Rhoda for this keynote address. Another round of applause. We are going to, after break, we are going to the breakaway sessions, which will begin at exactly 11. So, just to wrap up, to give you a snapshot, here in Bunyonyi, it will be my brother, Dr. Ibrahim Chirunda, who will be the session chair, and the theme is governance and special groups. In Aswa Hall, it will be Augustine Muhezi, and the theme will be improved service delivery models, medicines, and health supplies. And in Kafu Hall, which is also downstairs, the session chair will be Bogere Daniel, and the theme will be service delivery and infrastructure. So let's, our colleagues, our delegates online, just take this moment, but just know that the links to the different breakaway sessions are going to be reposted again in the chat so that you pick which you need to log out from one and join the other and where you want to participate in the different presentations. Bon appetit, and see you at 11 in the different 3 halls where we're having the breakaway sessions. Thank you.